All right, everyone. Welcome back to all my listeners. This is episode 1 in season 17. Today is Wednesday, February 4th, 2026. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Wow, hearing myself say all that after a month on sabbatical is a joy. I'm so happy to be back. All of my podcast listeners around the world. I hope you didn't miss me too much, but I know I missed all of you the entire month of January. So I took a much needed sabbatical time with family. We went traveling to India for just under a month, and it was a simply remarkable time. I haven't been back to India in, a couple of decades, but before that, I was in India at least 10 times. And, there's been so much change that I witnessed in the country. It is still a joyous, vibrant place, full of so many different points of view, so much beauty, so much food. My 5 senses were overwhelmed in delight. We traveled from all the way down in South India, all the way back up to where I am from, the state of Gujarat in India. My family was from small little villages there in a southern part of the state. And we actually went exploring in quite a few of the bigger cities in the state of Gujarat and visited lots of temples and enjoyed great food for the weeks that we were there. It was just an amazing place. I highly recommend folks go to India at least once in their lifetime if they can. It is truly a remarkable place. Unfortunately, we all did get sick since, of course, it's family. We were in close quarters, driving around in our party bus for the weeks. So, once someone got a little cough, it quickly spread. But then we all got a virus. I, of course, in healthcare, I brought along my COVID tests, but they were all negative. So it was definitely some sort of a India virus, a big bad bug that we all contracted. We spoke to one of our friends there who happens to be a doctor, and he definitely told us, yes, there is something going around the country, and everybody has this vicious cough and cold. Lots of drainage, and we had all of that as well. So we were pummeled. So you'll excuse me if I'm deeply coughing. I'll have to put the microphone on mute, but I'm still recovering as well. But, I can't wait to go back. I know a lot of my family is much older than I am. So, of course, they're exhausted, and I'm not sure when they will go back. Or if we do go back, it'll be something much simpler. We'll stay in one town and just really enjoy that place instead of, taking multiple flights internally, taking the party bus, 4, 5, 6 hour drives. It was very tiring. But again, the landscape and the people you simply cannot beat. India is amazing, and I simply loved it. But I'm happy to be back home, back on U.S. soil. It's definitely a blessing. Breathing clean air. I know India is really gung-ho on their multiple platforms and initiatives to improve the environmental toxins and pollution and all of that. But, as a foreigner, I'm not from India, or I haven't lived there ever. So technically when I go there, I am a foreigner, and my body is accosted to the pollution and the toxins that are in the air, right? So you definitely feel a big difference, even though when you just walk around and look at the air quality, you can't see anything, right? It looks like normal air that you are breathing, but it's definitely very different, definitely much more polluted than the air quality here in the US. So definitely glad to be back. And of course, I came back to a winter wonderland and completely Arctic air temperatures here. So, it definitely did help and tried to kill the virus that we all contracted over there in the tropical, warmer climate. So even though India is in their winter, right now, it was still an absolutely gorgeous 80 degrees every day, no humidity. It was my perfect temperature. So I really enjoyed it. And I love having a tan in February. So I'm definitely happy. And of course, we did shopping and got some good clothes and, got a lot of spirituality from visiting so many different types of temples. It was just a magical experience all around. I definitely love it. Loved all the food. Their coffee could be much improved. But I definitely enjoyed drinking coffee every day and a lot of really fresh fruit juices every day for breakfast. Bottled water galore, of course. Ginger ale, Limca, Thumbs Up. Those are their Indian drinks. Gold Spot. That's their orange Fanta-like drink. But you guys, I just love India. I could talk about it forever, but that's not what this podcast is about. But I really wanted to let you guys know where I was for the entire month on my sabbatical. So I'm really happy to be back, happy to be working, and happy to bring the podcast back for another season, right? Season 17. So I've got a lot of new things in store for the season. I'm hoping to bring back a lot of my fabulous guests on the podcast. So you can definitely see me conversing with others instead of just me talking as a solo podcaster. I love all of my colleagues and collaborators, and I can't wait to bring some of them back to definitely talk about everything that's going on in healthcare as of 2026. So anyways, I just wanted to let you know my update personally. But let's move on to today's Newsworthy. It's going to be focusing on the 5 new telehealth services that were included in the calendar year 2026 physician fee schedule final rule. And in my trusty tip, I wanted to focus on an article that I wrote for NAMUS, the National Alliance for Medical Auditing Specialists, on audit plans for telehealth, right? So both Newsworthy and trusty tip are going to go hand in hand very, very nicely. Like I like to curate, right? Over the years, I like when my Newsworthy and my trusty tips go hand in hand. So definitely I will be focusing on telehealth. I'm going to be providing some really great tips, I think, that providers of telehealth services really need to keep in mind. And my article talks all about them, but I'm just going to focus on a few of those tips. And especially during all of the periods of flux that we've been experiencing these past few months with the government shutdowns that affect the Centers for Medicare and Medicaid Services, our CMS. So I can't wait to unpack that in my trusty tip. And of course, I'm going to go ahead and close out and round out today's episode in Spark and focus season 17 with remarkable quotes on beauty, abundance, and innovation. And again, I am alluding to my brilliant January 2026 trip to India. So I'm definitely going to be talking about that in Spark for the entire season 17. And today's Spark is from Kahlil Gibran. All right, you guys, let's get into it. So in today's Newsworthy, of course, I missed discussing all the new CPT codes that took effect on January 1st, 2026, because I was in another country. But I can talk about what's new in telehealth for 2026. Now, Medicare put out a wonderful update to their telehealth and remote patient monitoring MLN booklet that highlights what's new for calendar year 2026. They finally removed the distinction between provisional and permanent services for the Medicare telehealth services list. They now consider all services they add to the list to be permanent. Finally, right? The spreadsheet file that they had developed since the pandemic was always so very confusing to me with those terms, provisional and permanent. Those markings were very, very confusing. I never understood it. But now we can breathe easy. Everything will just be considered permanent. Moving on, CMS also says that based on several telehealth provisions in the calendar year 2026 physician fee schedule final rule, they added these services to the Medicare telehealth services list. Number 1, multiple family group psychotherapy. And that's highlighted with CPT code 90849. Number 2, group behavioral counseling for obesity. And that's highlighted with HCPCS code G0473. Specifically, that HCPCS code is defined as a face-to-face behavioral counseling for obesity group 2 to 10 people for 30 minutes. Number 3, they've included the infectious disease add-on code, which is highlighted by HCPCS code G0545. And be mindful, that's a brand new code for 2026. Now, G0545 is defined as visit complexity inherent to hospital inpatient or observation care associated with a confirmed or suspected infectious disease by an infectious disease specialist, including disease transmission risk assessment and mitigation, public health investigation, analysis and testing, and complex antimicrobial therapy counseling and treatment. In parentheses, it says add-on code list separately in addition to hospital inpatient or observation evaluation and management visit, initial, same day discharge, subsequent, or discharge, end parentheses. All right. And then the 4th code they've added to the telehealth services list is for auditory integrated sound processor. And that code is for CPT code 92622. And finally, the 5th code that they've added to the telehealth services list is also for the auditory integrated sound processor code, and that is for CPT code 92623. Now, specifically, CPT code 92622 is defined as diagnostic analysis, programming, and verification of an auditory osseointegrated sound processor, any type, first 60 minutes. And finally, that CPT code 92623 is defined as diagnostic analysis, programming, and verification of an auditory osseointegrated sound processor, any type, each additional 15 minutes. And in parentheses, it says list separately in addition to code for the primary procedure, end parentheses. And now it's time for my best practice tips in Trusty Tip. Now, I'd love to read just a couple of really helpful tips from my latest article from NAMUS. And of course, it's regarding audit plans for telehealth services, especially those office visits that are rendered via telehealth. Now, if you've been a loyal listener on my podcast, you know I've been talking about telehealth for a number of months now. This has been a pretty topsy-turvy year for telehealth. I had the playbook for telehealth services with my good friend Keisha Wilson. That is still ongoing and being developed, tweaked, and changed, right? Since we do have a lot of changes. So I've been talking a lot about telehealth to the podcast audience as well as my own clients over this past year. So I thought it was really, really good that I write an article for NAMUS regarding my best tips for practices to start developing an audit plan for this particular service line. So, of course, I'm going to be talking about, right, those audit plans for telehealth services, especially those office visits that are rendered via telehealth, because that is something I see in the work I perform every day as I audit. Now, the article starts with step number 1, develop a current telehealth payer matrix. So identify how payers will reimburse you for office visits rendered via telehealth. Stratify by government and commercial payers. So that's a lot of work to develop a payer matrix in general, right? But someone on your team should be well aware of how to do that, how to conduct that research, how to make sure that they compartmentalize all of the payers that you accept at your practice, because every single payer has their own guidelines and payer policies on how telehealth services in a office place of service are going to pay you. So make sure that someone on your team knows how to develop a current telehealth payer matrix. Now, my article moves on and talks about step number 2. Step number 2 is for identify correct coding, and that's a must, right? So telehealth is multifactorial. So you should definitely be aware of the place of service. That's also a code, right? So correct coding for place of service. Now, Medicare prefers place of service, or POS 02, for telehealth provided other than in a patient's home, and POS 10 for telehealth provided in the patient's home, which is a location other than a hospital or other facility where the patient receives care in a private residence. Now, the article goes on and talks about commercial and Medicaid payers may prefer place of service 11, which is for office, with a modifier identifying the service as rendered via telehealth. So both of those things are different, right? Medicare is often different than commercial. Medicare is often different than Medicaid. So make sure, again, that someone on your team is well aware of identifying these types of correct coding situations in a payer matrix. Now, in your payer matrix, it's important to verify every payer's preference when auditing telehealth services. And I can't stress that enough. You can't just use one cookie cutter template when you're auditing for various payers. Each payer, more often than not, is going to be uniquely different than the previous payer that you just audited. So make sure you stay very current. Now, my article also gives a nice little asterisk, a little scary point, which of course I talk about here on the podcast, all the scary points, right? And I say the Office of Inspector General, that's the OIG, and the Special Investigation Units, those SIUs, are identifying place of service, or POS errors, as a top cause of reimbursement errors. So yeah, that's a pretty scary sentence that I wrote in that article, but it is a fact. The OIG is looking very closely at these types of office visits rendered via telehealth, and the SIUs throughout the commercial payers are looking at the same thing, right? And they have identified that these place of service errors, POS errors, are a top cause of reimbursement errors. So I implore all of the providers in my audience to be well aware of that fact and do a better job and start conducting those internal audits, because those are there to protect you, to keep your reimbursements the first time. Now, my article moves on and talks about modifiers. Medicare prefers the modifier 95 for synchronous telemedicine service rendered via real-time interactive audio and video telecommunications system. Modifier GT for service rendered via real-time interactive audio and video telecommunications system is still preferred by some commercial and Medicaid payers. But, fun fact, Medicare stopped requiring the modifier GT on professional claims as of January 1st, wait for it, 2018. So again, the discrepancies between all of these payers are still there. So modifier GT may still be warranted on Medicaids or some commercials, but definitely do not use that modifier. It's invalid. It has not been in use since 2018 for Medicare. Now, my article goes on and talks about Medicare preferring modifier 93 for synchronous telemedicine service rendered via telephone or other real-time interactive audio-only telecommunications system. Note, this modifier is for use with CPT codes listed in Appendix T of the CPT Code Manual. Now, understand and apply other applicable telehealth modifiers like FQ, FR, GO, and GQ as appropriate. Now, my article continues and talks about CPT codes. This is very important, right? Medicare prefers telehealth services to be billed as evaluation and management, or E&M codes, for office and other outpatient services developed by the American Medical Association, the AMA, for CPT. Now, these codes, I've talked about this over the years as well, these E&M codes for the office and other outpatient settings are for the CPT code 99202 through 99215 for new and established patients. So Medicare has been using that set of codes for a very long time for telehealth services. But there's a little caveat, there's a small wrinkle here in that the AMA and CPT created a whole new set of codes that range in the 98,000 range, specifically for codes 98000 through 98007 for new and established patients. So those codes are all for the telemedicine synchronous audio and video E&M codes that the AMA developed for CPT. Now, there are even newer 2025 telemedicine E&M codes for synchronous audio only E&M services, right? And these codes range from 98008 through 98015 for new and established patients. Now, I'm curious though, because I don't know who actually pays this new subset of codes. So again, make sure you have people on your team looking at the payments, looking at those EOBs, right? What commercial payers are actually paying on these 98,000 sets of E&M codes specifically created for telemedicine. So I'm curious, and are these codes actually even loaded into your electronic medical record system, your EMRs? So I wrote that in my article as well, just to be a little tongue-in-cheeky, but I really am curious because I do not know who is actually reimbursing for these new codes. Now, fine print again, a little caveat, a little wrinkle. I write in the article, the OIG and SIUs are identifying E&M errors as a top cause of reimbursement errors. And of course, that's a fact, right? Because they are worried about the levels of those E&M codes. So that's still a factor, even though the services are rendered via telehealth. And then finally, I talk about step number 3 in the podcast here. I'm going to stop. My article goes over 5 steps, but I'm going to stop at step number 3. Step number 3, ensure adequate documentation. And that is my very favorite step in this audit plan, as well as in any audit plan that your practice is conducting. Now, telehealth encounters require adherence to multiple elements to justify reimbursement. And that's a big, important sentence. Let me read that again. Telehealth encounters require adherence to multiple elements to justify reimbursement. So things that I see lacking: patient consent. Documentation must include that the patient verbally consented to a telehealth encounter after all of the risks to the mode of healthcare delivery have been presented to the patient. A detailed, separate telehealth consent and/or a financial responsibility form is also acceptable. Now, I also see lacking in documentation the mode of communication. So now encounter notes must state the HIPAA compliant mode of communication used during the patient visit. And I can't tell you how many times I see that as missing. And as a coder, as an auditor, I cannot guess, right? If it's not documented, I do not know how that session was conducted. How was it conducted HIPAA compliantly? Now, for example, the Office of Civil Rights, the OCR, allows the use of telehealth platforms that are compliant with HIPAA rules and when they are entering into business associate agreements with platform vendors. And all that means is you are paying for a platform, right? Gone are the days of the pandemic where OCR allowed us to use FaceTime or Skype or things that were free, right? No, the pandemic was long gone, right? And OCR implemented rules that things need to start utilizing HIPAA compliant platforms and vendors. Therefore, we have to agree to business associate agreements and start paying for platforms. So Doxy.me and Zoom for Healthcare are 2 very good examples of HIPAA compliant platforms. Now, my article moves on and talks about audio-only visits must also be clearly identified in documentation. And of course, that is also lacking. We have to talk about provider and patient locations in documentation as well. And of course, that is negligent as well. I really need to understand where the provider is, and where the patient is located. And are these spaces HIPAA compliant? I've seen many a behavioral health encounter where practices are trying to use place of service 99 for other location, right? And whenever you choose a code that is for other, or it's not really as descriptive as it could be, that's going to give a payer pause, right? And they're going to really come back and ask for documentation to help support why that other place of service was actually chosen, right? Like, where is the patient that they're not at home, or they're not at a facility, or they're not at an office, right? So where are they if they're somewhere else? So documentation must be capturing the locations of both the provider and the patient during the telehealth service, even if the encounter is audio only. Now, note, Medicare also requires that a provider must be technically capable of using video. But what happens when the patient cannot use or does not consent to video technology? In those instances, the provider must document the patient's inability to use video or their lack of consent. So that is a must, right? Because sometimes people don't want to be on camera, right? Or sometimes your patient population is much older and they don't even have a smartphone or an iPad or any such technology that allows them any type of video, audio capability. So we just need to note that in documentation. Now, also, best practice includes start and stop times. Best practice recommendations include documenting start-stop times for time-based office services like psychotherapy rendered via telehealth. Now, my article goes on, and I'll provide a link in the show notes, but please make sure you stay current and aware of all of the changes happening in telehealth for all the insurance carriers you take at your practice. Best compliance practices include updating your audit plan at every stage of change. And finally, I focus a brand new season 17 Spark on beauty, abundance, and innovation. Again, the new season is focused on my recent inspirations taken from my trip to India. I want this 17th season Spark to be filled with our world's thought leaders, writers, artists, philosophers, everyone whose words provide us with their insights on beauty, abundance, and innovation. So, in this week's inspiring quote in Spark is from Kahlil Gibran. Beauty is not in the face. Beauty is a light in the heart. So very true, right? It's a brand new year. Where are you getting your inspiration from in 2026? I'm always thinking about art, about fashion and beauty. These are things that bring me happiness, things that fulfill my soul. Vibrancy and beauty are often defined as a reflection of inner joy, confidence, and authenticity rather than just physical appearance. I truly believe that. Kahlil Gibran's quote, "Beauty is not in the face. Beauty is a light in the heart." That quote echoes the sentiment beautifully. I'm happy Kahlil Gibran's spark still burns brightly and can still inspire so very many. All right, you guys, that wraps up today's episode. I'm so glad to be back, and I'm looking forward to all the new season has in store for the podcast. All right, you guys, I wish you all an amazing and very, very happy week ahead. It is the month of love, so I hope you've got some dates and some chocolates and some red wines bookmarked for February 14th. That's just in a couple of weeks. I hope you have some plans already in mind for that very, very special holiday. All right, you guys, thank you so much for listening on today's episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.